That's your afferent artery. I'm just going to draw this like this. That's your glomerulus, which is just a tuft of anastomosing capillaries. Now, basically, blood will flow in from the kidneys through this artery, which is the afferent arteriole. Afferent. So the name implies that it's the artery that begins blood flow into the kidneys. So blood will flow through this, then flow through this tuft of capillaries, which is known as the glomerulus. Understanding, and I've said this a million times, understanding renal pathology and disease process, you have to understand the anatomy. If you don't, you're just going to be memorizing, and that's useless. Okay, this is the efferent arteriole. Basically, blood will enter through this artery, the arteriole, pardon me, the afferent arteriole, go through this glomerulus. What will come out has to come out. What will stay, well, in a healthy person, what should come out will come out. What should stay should stay, and it'll exit through the efferent arteriole, which then becomes the peritubular capillaries, which eventually lead back to the renal vein. Okay? Now this capillaries, okay. Pretty simple so far, okay. The problem comes with azotemias. Azotemias means what? Elevated BUN and creatinine. Okay, that means without symptoms. When you develop symptoms of renal failure, then you have uremia. So it's only really definition-based, thing. So uremia is just azotemia with symptoms, okay. So you have a pre-renal, which is fairly self-explanatory, intrarenal, and a post-renal. So when something affects the kidneys that's before the kidneys, it's a pre-renal. When something affects the kidneys itself, which is one of the main parts, the constituents are the glomerulus, the tubules. So you have glomerulus and tubules. It's intrarenal. And if it occurs after kidneys, it's post-renal. Which post-renal is really the easiest one to understand because I think that's going to be simple for you guys to get. Where we're concerned with the urine studies that we do and some of the things that you guys probably have seen before in testing, you don't fully understand how they're important in the scheme of things and why some of these things are important. It's really when we're differentiating between pre-renal and intrarenal that you really have to understand the pathology and the anatomy. Okay, so we start with the afferent arteriole, we did the glomerulus, then we did the efferent arteriole. So let's do that again. Uh-oh. Have I done something wrong? Okay.
One of the student mics is actually on, so I just want to make sure everyone watch their bags and stuff.
Oh.
That one over there? Okay. Yeah, because the camera gets shifted away and they can't see you, so I just want to make
Oh,
sure.
I see.
Yeah. Make sure, as soon as they can see. Okay.
Are you guys able to see? Yes? Okay.
Yes, it is. All right, so I guess.
No, it's fine. Thank you for letting us know. Okay, so basically, where we have to understand, okay, again, afferent arteriole, glomerulus, and efferent arteriole. So this is your glomerulus. The glomerulus is a selective barrier, okay? It's made of three main parts. The glomerulus is endothelial, right? Capillary, that's what it is. But it's a special type of capillary. It's called a fenestrated capillary. And that means it has little holes in it, so it has fenestrations. This is one of the selective barriers that allows certain molecules in, certain molecules to diffuse simply, and certain ones not, like larger macromolecules, like globulin. So your glomerulus is capillary. It's a capillary with fenestrations. That's all it is. When we're talking about the glomerulus, though, it's unfortunately, like everything else, it's more complicated. So you have the glomerulus. So that's just the close-up of the glomerulus. Okay. Beneath it, you have that's your glomerular basement membrane. So we're going to call it GBM. And then we have your podocytes. Let's just go like this. Okay. Those are visceral epithelial cells. Visceral epithelial cells. They're also known as podocytes because of their structure. They have finger-like projections which come together and form filtration slits. Okay, these filtration slits are smaller in size than the fenestrations. So as you leave this glomerulus where your blood is being filtered, so your blood is being filtered to the glomerulus, you have some things coming out. So remember, the podocytes have filtration slits. You guys remember podocytes from anatomy? Okay, well, your renal corpuscle, which is the combination of your glomerulus, your glomerular basement membrane, and your podocytes or visceral epithelial cells, that's pretty much the glomerulus, which the sum total is called the renal corpuscle. Okay? So the fenestration, so remember these have little fenestrations, holes. These have little holes here. And they allow certain small molecules through without any issue. Okay. So far, you guys understand so far? Okay. That's your basement membrane. Really, the two parts of the lecture, once you guys get prerenal and intrarenal azotemia, the rest of this lecture is actually pretty simple. This is the part which, to me, is the most complicated. Okay. So you guys remember Bowman's capsule. So your visceral epithelium is the part of the epithelium that's connected to your glomerulus. So this is the rest of Bowman's capsule. Those are your parietal epithelial cells. So they don't have any special purpose. They don't have any special, there's regular epithelial cells. So that's your Bowman's capsule. So basically you'll have particles, sodium, potassium, things like that, leave the glomerulus, enter the Bowman space, right? That process is called is basically called excretion, because you're excreting it initially. Okay, so that's excretion. Your body's going to reabsorb pretty much all of this, and that's reabsorbed through the tubules. And believe it or not, most reabsorption takes place in the proximal convoluted tubule, the very first portion of the tubule. Okay, so here's your glomerulus. I'm just going to draw it like this, and your tubules. That's your proximal convoluted tubule, which goes down, comes the loop of Henle, goes up to the ascending loop of Henle, which becomes a lot thicker, and then goes into the collecting ducts. Okay, so that's your glomerulus, just a picture of glomerulus. Okay, why did I do that? I don't know. So again, this glomerulus is going to filter some substances. I'll make it colored. So that's the Bowman space. So remember, I showed sodium and potassium going into the glomerulus, into the Bowman's capsule, or the Bowman space. Pardon me. It's going to enter this tubule, which is proximal convoluted tubule. It's the first portion of the tubule. Majority of things that get reabsorbed, actually, it occurs in the PCT. So now what you're going to essentially have is now sodium leaving, potassium leaving, and other bicarbonate, phosphate, you name it, calcium, urea, tons of things leaving and going back. The little spaces between here are called mesangium. And it's just another cell. That basically makes up the bulk of the kidney. It's basically like the glue that keeps everything stuck together. You also have you guys remember you have your blood supply that kind of goes along the side of each nephron. So this whole unit is called a nephron. That whole thing's a nephron. That's what a nephron is. That whole thing's a nephron. Well, you have the blood supply right next to it. So as these substances leave this tubule and enter the blood supply, it's being reabsorbed. It's being put back into the bloodstream. You understand? Reabsorption. When it's excreted, it stays in the tubule and it goes out in urine. Excretion is when it moves out of the urine through the tubules. Reabsorption is the process by which it leaves the tubule and goes back to the bloodstream. So if you're not having reabsorption, you will lose all of these things in the urine. Okay? So now let's do glomerular disease. Your glomerulus, again, is a 3 layers. So that's the glomerular capillary, endothelial capillary, the basement membrane, and your podocyte. So I'm just going to draw next to it so I can try to start to explain to you why these different labs show what they do. Okay, so the first filtration mechanism is the actual glomerular membrane, the renal corpuscle. That's the first thing filtering everything. So everything, if nothing comes out of this, nothing goes in the tubules, right? So the very first problem, if you have an issue, would be with the glomerulus. So anything that causes disease of these 3 components, the 3 components again, 1, the glomerular capillary, 2, the basement membrane, or 3, the podocytes. Any problem with any of those 3, you have a glomerulonephritis. That's all that means. You have some kind of infective or inflammatory process, autoimmune process, you name it, genetic process actually also that can affect any 3 of these layers. You can, or affect all the layers. If you have any of that, then you have a glomerular disease. You have glomerulonephritis. So it's affecting the very first portion of the filtration. So if something's not going through the glomerulus, is it going to end up in the tubules? No. There's nothing going to be deposited in the tubules at all. So if the glomerulus is not functioning, that's the beginning. That's basically your initial entry point to the kidney. If that's not working, the tubules at that point don't even matter. Okay. So I want to make more space. Sorry. Glomerular basement membrane. And remember, the podocytes are just visceral epithelial cells with these foot-like projections. Right? These are like little foot-like projections that stick together. They kind of join. Again, they basically connect like this and form the filtration slits. So these are little slits between with my fingers. In fact, they call it interdigitating. So they kind of stick together like this and they form slits. Pardon me. Okay. Okay, let's say that you have a disease that's affecting the glomerulus now. Let's say IgA nephropathy, which is the most common form of glomerulonephritis in the world. The nice thing about glomerular disease is that it's pretty much across the board, it's standardized. Unlike problems with the renal tubules, you can have little variations in the in how the labs look. With the glomerulus, you either have nephrotic or nephritic syndrome. And it's basically that simple. Let's say the glomerulus, you have, let's say, IgA nephropathy, which is a type 3 hypersensitivity. So it's antigen immune Antigen, antibody complexes. Of what? IgA. They think it's caused by initiation with a viral infection. Unlike a streptococcal glomerulonephritis, it happens pretty immediately, within a day or so. So basically, you're producing this IgA, which your body identifies as not being itself. You have an antibody bind to it, or you have, pardon me, the IgA is the antibody. You have, pardon me, no, it's not. The IgA is actually the antigen, and you have an antibody binding to IgA. What happens with IgA, we don't know why this happens, but there's a galactose sugar on an IgA antibody, and for some reason, certain ones in this kind of condition, in the IgA nephropathy, become deficient of this galactose sugar. You guys don't have to remember this, but it's bizarre. So your body, because of the lack of galactose, it has just too little sugar attached to it. Your body identifies it as non-self, and an IgG or an IgM attaches to it. That's way too much information, I know, but basically that is your antigen. So your body thinks this is non-self and attacks it. These complexes, like I said, they're big. They get stuck in the kidney. That causes damage to the glomerulus. They basically get stuck in the glomerulus and start causing damage. Because you have they're big. Antigen, antibody complexes are big. They get stuck in and start causing damage. And they activate complement. So complement comes in and starts damaging your kidneys. Okay. What's going to happen initially is that, let's start with nephrotic syndrome. Let's say it progresses to nephrotic syndrome. The number I want you guys to remember is 3.5 grams of protein. That's when you have nephrotic syndrome. Okay? 3.5 grams of protein in your urine in a 24-hour period, that is nephrotic syndrome. So this IgA antigen antibody complex gets caught and damages the glomerulus. So let's say it pokes big holes here. Normally, because of the size of the fenestrations of the glomerulus and the filtration slits, albumin, globulin, all these proteins cannot pass through the kidney, right? That's why you should never have protein in your urine. If you all of a sudden develop protein in your urine, that means something has damaged this initial entry point to the kidneys, and that's your glomerulus. It has nothing to do with tubules. Remember, the moment you're talking about protein in urine, you're talking about the glomerulus. This is what prevents protein from entering the urine, is the glomerulus. So let's say you have IgA nephropathy that damages the glomerulus, and now you have protein spilling to your urine. Unfortunately, you can be actually pretty asymptomatic initially, for actually a long time, for years. You might not even know you have protein in urine. But let's say, for argument's sake, you feel fatigue, because some people can have fatigue. Not everybody does. Let's say you go to the doctor because you're feeling fatigued, and let's just say that he does a urinalysis and he sees protein, 4+ protein in urine. Well, it's going to lead him to start doing other testing, because that's, especially if he does a urinalysis and you're negative for any kind of leukoesterase or nitrates, so nothing to indicate you may have an infection. Because with an infective process, you can have inflammation in the glomerulus, and you can have protein in your urine then. So, which is a good point to bring up. If you have to rule out infection when you're looking at this. That's one of the first things you have to rule out is infection. Because with infection, you can have some protein in your urine. Not 4+ normally, but you can. So, okay, let's say now, so you have now IgA nephropathy damaging the glomerulus, which is an entry point of the kidneys. You should never have protein coming through this because the fenestrations and the filtration slits are small. Protein, like albumin, is about 10 microns, and the filtration slits are 20 to 30 nanometers, and the fenestration is about 80 to 100 nanometers. Protein can't normally fit through those slits. In this case, it does, because you have basically holes being poked into the fenestrations and through the podocytes. So you have protein spill out into the tubules, which then it gets passed to urine. The tubules have no way to really get rid of it at that point. The PCT, the proximal convoluted tubule, because the loop of Henle, the PCT and the DCT, proximal convoluted tubule, distal convoluted tubule, they don't have any way to really get rid of the protein. The protein is too large to pass through their membrane. And most reabsorption of substances in the tubules takes place through active process, meaning pumps that use ATP. Okay. I know it gets. I know the kidneys are really complicated. I believe me, I get it. I warned you guys. So basically, now you have a glomerulus that has damage in it, has holes in it, and this is basically how all glomerular disease begins. You get damage to glomerulus, you have holes poked into it, then you have substances that shouldn't pass through, specifically like protein, pass through. So the moment you have protein in your urine, it's abnormal. Once you get to 3.5 grams in a day, you have a nephrotic syndrome. What's going to happen if you're losing all this? And that's the only symptom so far, because believe it or not, you have no other symptoms. There's usually no blood yet in your urine. You can have sometimes a little bit of blood, but a small amount of blood. It's not a lot because you have damage to glomerulus and you have a little bit of bleeding, but nothing major. Let's say you have a little bit of blood. So you have mild hematuria. Nothing that's visible, though. It's going to be microscopic hematuria. You're losing protein. What's going to happen? Oncotic pressure is going to go, right? Right. So what's going to happen? You're going to have third space. So you're going to have basically the main thing keeping fluid in your blood vessels going out through your kidneys. Oncotic pressure is going to drop, which is the main driving force attracting fluid back to the vascular space, because you have hydrostatic pressure pushing it out, right? Then you have oncotic pressure pulling it back in. If you lose all your protein, all your big molecules, your albumin, fibrinogen, and your globulins in the urine, your oncotic pressure is gone. So you're going to have, what are you going to develop? Anasarca. That's the big, with nephrotic syndrome, you develop anasarca, which is edema beyond edema. That's when your whole body is basically swollen, okay? So you have, again, that's the 3.5 grams. The reason I'm using that number, because that is, you have to get that amount to have, you can have more than that, but you have to get to that amount to have nephrotic syndrome. So because of the loss of protein, so let's just draw it like this. So you develop hyperproteinemia. And that's, I'm not specifying, because you lose globulin, you lose albumin, you lose all the proteins. You have hyperproteinemia 1. That's going to cause decreased oncotic pressure, which is going to equal anasarca. Right, is everyone on the same page so far? Okay. Your liver is actually really smart. Your liver realizes that all of a sudden you have this reduction in proteins, in plasma proteins. So your liver can ramp the production. It can actually, your liver can produce, if you're eating enough amino acids, you can actually produce up to 12 grams of protein a day, which is a lot, believe me, that's a lot. Unfortunately, with nephrotic syndrome, you can lose all of that. So, and in fact, if you do have nephrotic syndrome, you actually are going to lose all of that because the kidneys already got holes in it. So now, and when I say the kidneys, it's the glomerulus. We're speaking about the glomerulus specifically. Okay, so you develop anasarca, liver senses, liver picks up on it. Increase plasma protein production. Unfortunately, the liver, as smart as it is, it's also kind of stupid. What it also ramps up production of, and this is one of the hallmarks of nephrotic syndrome, it doesn't just increase plasma protein production. Unfortunately, it also increases bad lipid production at the same time. So it's a byproduct of the liver's adjustment to try to increase your protein intake. It automatically increases bad lipid. I'm putting bad lipid because it's bad lipid. So what does that mean? Your VLDLs, which your VLDL is what we're talking about here. We're talking about triglycerides, right? LDL. There's intermediate density where I'm going to put. And so what's going to happen to HDL? It's going to drop, yeah. You can actually get dyslipidemia so severe with nephrotic syndrome that your cholesterol can go literally in the thousands. Okay, so now you have somebody now with hyperproteinemia, anasarca, and elevated lipids. You can have so many lipids that you actually pass lipids in the urine, which is called, because now remember, lipids won't normally pass in the urine, but now you have holes in your glomerulus, so they'll pass through those massive holes, so you have this hallmark, lipiduria, lipiduria. Literally, you're passing lipids in your urine. And you also see this. This is, you can look at, because they might, on a urine analysis, with microscopy, you might see the pathologist say that he sees fat oval bodies. Basically, that's what they are, fat oval bodies. You know, it's not really funny, but okay. I'm exhausted. So your urinalysis with microscopic, UA with microscopic, is going to show fatty oval bodies. So far these are you were talking. This is pretty much the male hallmarks of nephrotic syndrome: hyperproteinemia greater than 3.5 grams a day, anasarca, increased lipids. Now you guys understand why all this is happening. Right? So your liver's trying to compensate. So now, what's going to happen with the hyperproteinemia and the anasarca? You're going to have a drop in BP, secondary to third spacing, right? So you have two primary mechanisms. Your hypothalamus in your brain actually is the key to your osmoreceptors. It's going to sense that the blood is what? Is the blood concentrated or is it dilute? It's concentrated. You're losing all that fluid. So it's going to sense hemoconcentration. What does the hypothalamus produce? You guys should know this. And it stores it, ADH, and it stores it, the posterior pituitary is only the storage form, is only the storage area. And the posterior pituitary releases the ADH in the bloodstream. So is ADH a hormone? Yes, it's in the bloodstream. Automatically it's a hormone. Remember I told you guys that, hormone. And antidiuretic hormone ends in hormone. That's a giveaway. Okay. Okay. So now you have a situation where your blood pressure is dropped because you have less fluid in your vascular space. You develop hemoconcentration. The osmoreceptors in the hypothalamus sense this. The hypothalamus then causes the posterior pituitary, which is also called the adenohypophysis, to release ADH in the bloodstream. ADH then does what? ADH works in the DCT and the collecting ducts. Okay? It makes it impermeable to water. So you have ADH going, antidiuretic hormone, you're not going to diurese. So your body's now retaining more fluid. Unfortunately, nephrotic syndrome, it doesn't matter. It does not help. It's not enough. So what's going to happen? What's going to happen to this fluid? Because you have, again, the main issues, you have these plasma proteins that your liver's pumping up production, but you keep losing all in the urine. So your body is going to try to compensate every way it can. Your liver is going to keep producing these plasma proteins. Your body is going to try to clamp down by increasing production of ADH to store more fluid. No, not yet. Unfortunately, that doesn't occur in your body because it usually doesn't occur in nephrotic syndrome. It can if you have a bad heart. But let's say we're talking about a person with a good heart. So no, let's say no. The heart's handling all this. It's under duress, but it's handling it. And because the edema is so widespread to the body, people usually actually don't develop congestive heart failure from nephrotic syndrome. If you have a bad heart, that's another issue altogether. Don't make things complicated, please. Okay. So it's impermeable to water. So you're going to retain more water. Unfortunately, this water is just going to produce more anasarca. So you're going to get worsening edema from this. So it's remember positive feedback. You've tried trying to fix it, but it's making the edema worse. Your kidneys are also going to sense it, right? Your JGA cells, which the juxtaglomerular apparatus is right by the glomerulus. It also senses. It senses what that actually senses is more of a pressure. So it senses that there's reduced pressure in the afferent arteriole. So it's going to produce what? Renin, right? Renin is going to make angiotensin 1 to 2, okay, on aldosterone. So RAS system. What I'm mainly concerned is aldosterone. So the aldosterone is going to be produced. So now you have aldosterone being produced because of the decreased blood volume of the kidney. Because remember, all this blood fluid is going right into the interstitial space. So aldosterone is going to cause retention of what? Right. Unfortunately, when your body does this, so it makes now the tubules, it makes the distal communal tubule open to sodium, right? Well, when it does this, it also increases reabsorption of urea. That's important. So you're going to have increased urea reabsorption. So the moment you have aldosterone work, It opens up that DCT. You're also going to have urea rushing back into the bloodstream, okay? So that's why that happens. So it's called the action of aldosterone making, and ADH actually making the distal convoluted tubule and the collecting ducts permeable to sodium and water. You're going to have urea also enter passively. So you're going to have urea in the bloodstream go up. Remember, reabsorption back into the bloodstream. All this, bloodstream, right? So when I check a fractional excretion of sodium in the urine, what am I going to, is the sodium going to be high or low? Fractional excretion of sodium in the urine. Your body is reabsorbing all this sodium because of the action of ADH and aldosterone. So you know that it's going to be low. Urine sodium, is that going to be low or high? We already know that because of ADH and aldosterone, your body is not excreting sodium. So the urine sodium is going to be what? Low. Right. Let me just put this screen also. So urine osmolality, what's that going to be? Remember, we're talking about increased reabsorption of sodium, right? Not of anything else, sodium. Where sodium goes, remember I told you what two things are following. I said two things are following, water and urea. So what's happening to the urine osmolality? It's going to be high or low? It's going to be high. Urine osmolality is going to be high. Which means what? Osmolality means your urine is going to be concentrated or diluted? Concentrated. Remember, your body's trying to hold on to the water. Your body's holding to the water. The water is staying in your body. Unfortunately, it's not staying in the vascular space. So urine osmolality is going to be high. So you understand why these tests actually allow you to find the diagnosis? So urine osmolality is going to be high. And remember, I update the renal notes to reflect the numbers. So you're talking about, so it's going to be high, greater than 500. The urine sodium is going to be low, less than 20 milliequivalents a liter, which is usually less than 10. It's usually even less than that. Fractional excretion of sodium is going to be less than 1%. Now you understand the mechanism, right? Your body's trying to hold on to sodium. So low, less than 1%, secondary to aldosterone. I'm putting the mechanism. Okay? Your urine osmo is going to be high. Secondary to again, aldosterone and ADH is concentrating urine. In feeble attempt to increase intravascular volume. Okay? And then your urine sodium, obviously, low, less than 20 milliequivalents a liter, or millimoles. Secondary to, again, aldosterone. So you guys understand the pathology. Now you understand why. So your glomerulus has these holes in it. All the protein spilling out the urine. Your body can't hold on to the fluid. You have increased hydrostatic pressure, reduction on oncotic pressure. You develop edema because of this. Your body ends up sensing this. Your liver kicks in, starts producing more plasma proteins. Unfortunately, when the liver does it, also starts producing more of the bad cholesterols, the bad lipids. So your lipid level, you develop severe hyperlipidemia and actually have lipids floating around your urine because now you have holes in the glomerulus and the lipids pass freely through there. Okay. Your body produces ADH and aldosterone in an attempt to kind of increase fluid volume because it senses that, number one, that your blood is hemoconcentrated, and number two, that you have less fluid volume. So the brain is sensing that you have your hemoconcentrated, and the kidneys are sensing less pressure. So they're producing ADH and aldosterone, respectively, to increase vascular volume. Unfortunately, you keep this protein spilling, so the fluid is still third spacing. So they're making this person a bigger water balloon. Okay. And now the last thing we talked about is BUN and creatinine ratio. Remember I told you, you're having sodium and water being reabsorbed, and also urea. So urea is going reabsorbed back into the bloodstream. So what's going to be the BUN? It's going to be increased. So the BUN creatinine ratio is going to be what? Greater than 20 to 1. Right? you guys understand the mechanism? So if you have a person with this kind of presents with anasarca nephrotic syndrome, and you do these urine tests, you know they have nephrotic syndrome. You know they do. What the cause of it, that's another issue altogether. But you know that nephrotic syndrome. You guys really understand that? Understand all the pathology and the pathophysiology? And this is intrarenal we're talking about. We skipped intrarenal. Prerenal is easier, and so is postrenal. That's why I want to do intrarenal first. So no, it's a glomerular. It's affecting the glomerulus, so it's intrarenal. It's affecting the glomerulus, intrarenal. It's affecting a part of the kidney itself, so it's intrarenal. Okay. So we covered nephrotic syndrome. Well, you think that's bad enough, but nephritic syndrome actually is when nephrotic syndrome gets worse, believe it or not. Yes. Yes, no, please, no. Oh, yeah. No, nephrotic syndrome, she asked if nephrotic syndrome was acute or chronic. Nephrotic syndrome begins acute. It can last for quite some time if you don't find the cause of issue. And sometimes it does not progress to nephrotic syndrome. Sometimes if the damage is not a permanent form of damage, depending on what's causing the glomerulonephritis. With IgA nephropathy, it usually won't cause nephrotic syndrome actually, initially. It takes Berger's disease, which is IgA nephropathy, usually takes 20 to 30 years to destroy the kidney. But depending on what's causing the damage to the glomerulus, really dictates whether it's acute, chronic, or will subside at some point. In some forms of glomerulonephritis, you have self-limiting forms, which your kidney will thankfully come back. Some forms of glomerulonephritis, that's not the case. You're going to buy a new kidney basically. With IgA nephropathy, with time, if you live long enough, you will need a kidney transplant. The majority of people will. Unfortunately, with a transplant, because IgA nephropathy, they don't fully understand the pathology of it. Especially if you get a kidney from a relative, you're more likely to develop a reoccurrence of the IgA nephropathy. So people with this usually get more than one kidney transplant. They usually get two. Okay. Because it's one of the forms of glomerulonephritis that does reoccur. But again, it's the most common worldwide. So it's a good one to know. Okay. Yes, you can ask any questions you want.
You just said that was all like intrarenal.
That's intrarenal. That's glomerular. Right. That's nephrotic syndrome intrarenal, yes.
So then this chart that you made, those numbers that you listed are all listed under prerenal.
Right. Okay. So yes. We'll get to that. Yeah, unfortunately, prerenal, but yes, because with prerenal azotemia, a lot of the issues are the same. I was going to get to prerenal. With prerenal azotemia, the main cause of prerenal azotemia is a hypovolemic issue. So she asked because if you look at the urine tests and some of the blood tests for prerenal versus a glomerular intrarenal form of kidney failure or azotemia, yes, the actual workup in terms of the urine tests and some of the blood tests are going to be very similar. Where you get the difference is the presentation. You're not going to have someone passing 3.5 grams of protein in urine. You're not going to have someone with anasarca. You're not going to have any of this. And with prerenal, you can usually identify the problem. Like a person just had a massive heart attack and went to cardiogenic shock. Prerenal azotemia. You usually know what's causing the azotemia and prerenal cause. Hemorrhage, shock, DIC, whatever, anything that reduces volume to the kidney. So prerenal basically is a reduction in volume to the kidney because of an acute event that happens before the kidney. So anything that can potentially interrupt blood supply to the kidney, like what? Blood loss, right? Shock. Yes, you go outside and you work outside for way too long. You can go into a prerenal azotemia, absolutely. So dehydration can absolutely cause it. So because your body depends on the same mechanisms to concentrate your urine, the urine tests are going to be the same. Let's just go to prerenal since you brought it up. So prerenal is really before kidneys, and it's almost always volume related. So volume, I'm just really speaking generalized, volume, blood, whatever, loss of plasma, whatever the case may be, fluid loss primarily. Anything that you have a volume loss will cause a prerenal azotemia. So if you lose enough volume, your kidneys will sense that it's lost volume and it will affect the kidneys. So azotemia meaning elevation in BUN and creatinine. So pre-renal is volume, blood loss, shock, dehydration. Okay, you guys get the point. So all of this happens. What's going to happen? Your kidneys are still going to pick up on this, right? You still have protein in your vascular space. So the compensatory mechanisms that are going to kick in are going to be pretty much similar, but you're not going to have the constant loss of protein into the urine, and you're not going to, and as a result, you're not going to have the swelling, the edema valve, because you're going to have enough oncotic pressure. So now pre-renal, so you cause that. So now you have decreased blood supply to the kidney. Okay, here's your afferent arteriole, here's your glomerulus. Let's say here's your JGA cells. Juxta glomerular, I'll just write it out. Your kidneys are going to sense, and this is the afferent arteriole. This is where fluid is entering the kidney. That's your entry point through the glomerulus, and then exit is the efferent. Remember, the efferent just shunts it back to the renal vein. So efferent to renal vein. Okay. Your body's going to sense, your kidneys specifically going to sense a decreased blood flow in the afferent arteriole, right? The kidney's job is to perfuse itself. The kidneys have their own renal mechanisms to ramp up production of fluid if it senses that it's not getting enough fluid. So your kidneys are trying to, it's renoprotective. Your kidneys are trying to protect itself. Your brain only kicks in actually usually later on, and if your kidneys can't compensate for this issue. Okay, so what are your kidneys going to do? What are your kidneys going to do? I want everybody to answer. Everybody, even in HBOI. You guys know what your kidneys are going to do. You're going to have reduction in, we're not talking about ADH yet, no. Renin, which is going to kick in the cascade of angiotensin and aldosterone, okay? Your kidneys are going to sense the reduction in fluid, and your kidneys are going to do what they have to do, which is renin, okay? And then you have the whole cascade. Angiotensin is what? It's a vasoconstrictor. So if you have systemic clamping on your systemic, are you going to have more perfusion to the kidney? Yes, you are. Yes, you are. If your systemic blood pressure goes up, you are going to, yes, you are. Come on, guys. This is basically hemodynamics. Systemic pressure increases. Systemic pressure is the pump driving blood to the kidneys. Absolutely, you're going to have more perfusion to your kidneys. Unfortunately, it's going to be the expense of high blood pressure. So unfortunately, at the same time, you're doing intimal damage. Intimal layer, your inner layer of your endothelium, when you have what causes damage in high blood pressure is literally the velocity at which the blood is flowing. Especially the bifurcations and bending of arteries is where you get the damage. You have blood literally slamming against the endothelial wall. You have the initial damage to the endothelial wall. Then you have the platelet formation. You have the fibrous plaque which forms, and your body will keep repeating this same cascade of events till eventually it ruptures. And that's where that's why increased systemic pressure will increase perfusion to the kidney. But again, at the expense of systemic hypertension, which is not a good thing. So your body's trying to, basically your kidneys are kind of selfish. It's trying to protect itself, but it's doing damage everywhere else. The kidney, right. And then you have aldosterone's action. So aldosterone is going to basically increase sodium reabsorption. Reabsorption back to the bloodstream. Remember I told you, when you have sodium reabsorption and water follow, so we're talking about, I want you guys to really understand this. So it's not memorization. I want you to understand the process. I demand it. Sodium retention. So automatically, if you have sodium retention, what's going to happen? You have water, and remember I mentioned in the distal convoluted tubule, you're going to have urea. So all of this is going to be, as one big happy family, reabsorbed. Reabsorbed, when I say reabsorbed, that means bloodstream. So let's look at the labs now. So based on that, your urine sodium, I hit green. Right, because where is the sodium going? Back to the bloodstream. Urine sodium low. Urine osmolality high. Why? Because your body is taking in more water, right? To use it to increase pressure to the kidneys. So urine osmolality is going to be high. Fractional excretion of sodium. Basically urine sodium and fractional excretion of sodium is like saying the same thing, basically. But not basically, it is saying the same thing. It's going to be what? Fractional excretion is going to be low, because your body's going to be retaining as much sodium as it can to increase water reabsorption. And then last but not least, BUN creatinine, which I just mentioned. Increase reabsorption of urea into the blood, now it becomes blood urea nitrogen, is going to increase the BUN creatinine ratio. So that's why, so if I ask you the difference between a pre-renal azotemia and an intrarenal azotemia secondary to a glomerulonephritis, what are you going to use? The presentation, how the person comes in the door. They come and they're like, oh, like they're hey buddy, And basically you'll see the periorbital edema with anaphylactic nephrotic syndrome. Have you ever seen someone with nephrotic syndrome? The periorbital edema is like nothing. It's like out of this world, man. They come in like they look like a monster. You're like, good lord. And they also will have lipid deposition they'll have lipid deposition plaques on their face also from the excess, because nephrotic syndrome can go on for quite some time, for years actually. Okay. So now you have nephrotic syndrome. So we covered pre-renal azotemia. That's that simple. That's why the presentation is the same as glomerular azotemia, because it's your body's going to try to handle it the same way, because basically in both conditions you have a reduction in vascular volume, and your body responds the same way, because those are only the mechanisms that your body has to respond. So pre-renal and intrarenal azotemia secondary to glomerulonephritis will present this in terms of the blood work and labs roughly similar. There we go. Okay. So then you have nephritic syndrome. Nephritic syndrome is really progression of nephrotic syndrome. Now, imagine you keep damaging the glomerulus. What's going to eventually happen? You keep damaging the glomerulus. Cells are sloughed off, believe it or not. And as more cells are sloughed off, more and more blood's going to start escaping. And so nephritic syndrome, you're going to start... I remember I mentioned nephrotic syndrome, you have some blood, but it's not a lot. Nephritic syndrome, you're going to have, because of progressive damage of the glomerulus, you're going to have blood start pouring out, literally pouring out from the glomerulus into the what? The tubules, okay? Where's that blood going to go? Into the urine, exactly. So you're going to have, and the tubules, you guys know how a blood cell looks, right? And you can have whole blood because the hole is poked. Blood is actually, a red blood cell is actually quite large. It'll pass right through damage. So when the glomerulus is really damaged enough, you'll have the red blood cell pass right through. Unfortunately, the red blood cell, because it's big, so now you imagine a situation like this. So you have, let's just say this is your Bowen's capsule of your nephron, and this is your proximal convoluted tubule. So that's your, sorry, you have your Bowen's capsule. So you have the red blood cell go out into it. This is your proximal convoluted tubule. It's bigger. It's going to end up squeezing in, and that's when you form what, you ever see that term, red RBC casts? It's basically it's squeezed through the tubule and it forms a nice cylindrical cast. It just crushes the red blood cell into that shape and is passed to the urine like this. It becomes a cast. In some of the cells, they hemolyze. Some of the red cells don't become cast. They hemolyze, and you have byproducts of red blood cell hemolysis in the urine. So can you have a bilirubin in the urine? Yes. So now we're talking nephritic syndrome. So RBC casts. Your granular cells, you still granular cells, or granular class. And that's literally just the cells of the glomerulus being sloughed off and dying and going through. So you see granule cast, red blood cell casts, white blood cell casts, because you have now white blood cells start spilling out into the urine. So you get it, as the hole in the glomerulus gets bigger, you have even bigger molecules that usually can't fit through, start passing through red blood cells, white blood cells. Then you have the actual components of the glomerular membrane pass up in the urine, and they're like epithelial cells that get sloughed off. So you can detect all this in urine. You can detect all of it. So now you have nephritic syndrome because you have bigger holes in the glomerulus, bigger holes. And really, glomerulus, it's not just the glomerulus, it's also the basement membrane and the podocytes. What's going to happen eventually with this process is that you're going to have enough damage to the tubules or clogging of the tubules with these. So that's your tubule. That's a red blood cell. It's glomerulus. Eventually, you can literally have clogging of the tubules with progressive destruction of the progressive damage of the glomerulus. And despite all the compensatory mechanisms, GFR is going to drop. Okay? So now you have nephrotic syndrome where you're passing urine, you're not oligoric, you're passing urine, just not a lot, but you don't really have blood that gets visible, but then you have progressive damage of the glomerulus, the base membrane, and the podocytes. So now you have bigger holes, now you have blood, white blood cells, granular cast, which is the epithelial cells being deposited in the blood. The moment you start seeing, if a person has nephrotic syndrome, you start seeing blood, that you see gross hematuria, it's over for that person. It's over, literally. Done. It's a done deal. They're going to go develop end-stage renal disease. It's over. Anyhow, you basically start looking for a transplant list for that person at that point. So now you have a reduction in GFR literally due to the clogging of the tubules and the destruction of the glomeruli. Well, what's going to happen if decreased GFR? Pressure in the actual glomerulus is going to drop. So believe it or not, you're going to have decreased protein excretion. Remember, excretion is when it passes into urine. And because of that, the edema is going to get a little bit better. Gets a little better. So you have a reduction in edema and the reduction in the amount of protein being spilled out because you literally have the GFR is dropping dramatically. So presentation-wise, it may look better, but in actuality, it's much, much worse. So you have less protein. So the protein excretion is going to go below. Protein is going to be less than 3.5 grams a day. Nephritic syndrome. So really the differentiation between nephritic and nephrotic syndrome is less protein and a hell of a lot more blood. Okay? So these persons will get oligoric because of the drop in what? GFR. So again, through decrease in GFR. So oligoric is what? 400? 24 hours. Eventually, what's going to happen to oligoric? No. And urea. And that's no urine being produced. So the GFR is going to drop. The patient is going to get much, much sicker. What's also going to happen then to these people? You have become anemic. Very anemic, right? And before nephrotic syndrome, you didn't have that. You didn't have this anemia. As the GFR drops, what's your kidney going to produce more and more and more of? Your kidney is going to kick up, it's going to ramp up the RAS system big time in an attempt to compensate. So you're going to have what's called malignant hypertension. The blood pressure is going to be through the roof, which is another differentiation between that and, you know what, let's do this. So. guys kind of get it? So your body's what? No, I'm not. No, it's fine. I can always go back too. I know I kind of violently hit these next pages all the time. And sometimes I don't know why I do it. So, malignant hypertension, anemia. Unfortunately, at the same time, in nephritic syndrome, even some more of the bigger molecules that you have, like ferritin, transferrin, which is what? It's the extracellular protein that carries iron. That's also going to be spilled in the urine. So it's going to worsen the anemia. So you have transferrin being spilled into the urine. You're going to have antithrombin 3, which is another large protein being spilled in the urine. Antithrombin 3 is what? It's to break up thrombin. So if you're losing all these nice proteins that help to calm down the clotting cascade, and specifically antithrombin 3 gets lost, is gone, goes away. I should done it's excreted. That's the right term. So what's going to lead you over into? In nephritic syndrome, you get thrombosis. And one of the most common places to get thrombosis in nephritic syndrome is renal thrombosis, renal vein thrombosis. Well, simple. Why is that? Because you're losing antithrombin 3, protein S, protein C, all of these proteins which help to counteract the clotting cascade. You're losing them in your urine. The other thing that you lose is complement. The complement proteins also get lost in urine, because unfortunately this stuff is traveling in your bloodstream and normally will not pass the glomerulus. If your glomerulus is chock full of holes, all this is going to pass in urine. So all your complement is going to go basically into the toilet. So one of the big things that complement does specifically is pneumococcal infection. Pneumococcal, it forms a capsid over itself. It's a very thick bacteria which is hard to penetrate. So your body has a lot of problem with it. The only system that's good at getting rid of pneumococcal is complement. If your complement is in the toilet, literally, this is a very common infection. Pneumococcal infections become very common. And it actually is one of the causes of death of these people. They get severe pneumococcal infections because they have no complement to destroy it. Complement literally makes a massive hole into this bacteria, and nothing can survive that. Without complement, pneumococcal infections become far more prominent. So it all kind of makes sense. If you follow the pathology and the physiology and the anatomy, you're like, okay, I get it. You're losing all these components that help to counteract clotting, so you're at risk for thrombosis. Specifically, renal vein thrombosis is more common. You lose complement, so you have increased risk of all infection, but especially pneumococcal, because complement is one of the main ways that we fight that bacterium. You have malignant hypertension because your kidney is going to overproduction of aldosterone and the renin system. You have blood because blood's a large molecule. Now you have a glomerulus full of holes. You have all this blood spilling out into the urine. Because of the drop in GFR, you actually have less protein being spilled out because all these other things are coming out. There's only so much that can come out of the kidneys at once. So you have less protein being spilled out because you have other products kind of pushing out of the way. So because of the reduction in protein, urea, you have a lessening of the edema. Not a loss, but a lessening. So you see how nephrotic syndrome will progress to this in certain processes. And that's the difference between them. And the real big difference is the blood, because that is like, if you have a patient with a history of nephrotic syndrome who's walk around, then all of a sudden they call you and say, hey, I just went to the bathroom and it looks red. That's a bad prognosis. I mean, basically you can unless there's something else going on, bladder cancer, something that you pray for, which I know sounds crazy, they're going through nephritic syndrome. Okay, let's take a 5-minute break, because I know that was. But that's glomerular disease right there. That's everything.